retardation, dwarfism, osteomalacia, muscular hypotonia and frontal prominence. Complicated cataract. JT refers to opacification of the lens secondary to some other intraocular disease. Some authors use the term secondary cataracts for the complicated cataract. On the other hand, many authors use the term secondary cataract to denote after cataract. Therefore, to avoid confusion and controversy, preferably, the term secondary cataract should be discarded in general. Etiology. The lens depends for its nutrition on intraocular fluids. Therefore, any condition in which the ocular circulation is disturbed or in which inflammatory toxins are formed, will disturb nutrition of the crystalline lens, resulting in development of complicated cataract. Some important ocular conditions giving rise to complicated cataract are listed here. Inflammatory conditions. These include uveal inflammations, like iridocyclitis, pars planitis, choroiditis, hypopyon corneal ulcer and Figure 9.20 snowflake, diabetic, cataract. Figure 9.21 sunflower cataracts. Endophthalmitis. Anterior uveitis is the most common cause of complicated cataract 2. Degenerative conditions such as retinitis pigmentosa and other pigmentary retinal dystrophies. And myopic chorioretinal degeneration. 3. Retinal detachment. Complicated cataract may occur in long-standing cases for glaucoma primary or secondary, may sometimes result in complicated cataract. The underlying cause here is probably the embarrassment to the intraocular circulation, consequent to the raised pressure. 5. Intraocular tumors such as retinoblastoma or melanoma may give rise to complicated cataract in late stages. Clinical features. Typically, the complicated cataract starts as posterior subcapsular cortical cataract (PSC). The opacity is irregular in outline and variable in density. In the beam of slit lamp, the opacities have breadcrumb appearance, polychromatic luster, i.e. appearance of iridescent colored particles offereds, greens and blue is a very characteristic sign, rainbow cataract. Diffuse yellow haze is seen in the adjoining cortex, slowly the opacity spreads in the rest of the cortex, and finally the entire lens becomes opaque, giving dirty white, figure 9.22, or chalky white appearance, deposition of oleomesomen and philiterstiges. Drug-induced cataracts. Corticosteroid-induced cataract. Posterior subcapsular opacities are associated with the use of topical as well as systemic steroids. Exact relationship between dose and duration of corticosteroid therapy with the development of cataract is still unclear. However, in general, prolonged use of steroids in high doses may result in cataract formation. Children are more susceptible than adults. Therefore, it is recommended that all patients with diseases requiring prolonged corticosteroids therapy should be regularly examined on slit lamp by an ophthalmologist. Further, intermittent regimes should be preferred over regular therapy, and whenever possible steroids should be substituted by nonsteroidal anti-inflammatory drugs and NSAIDs. Miotics-induced cataract. Anterior subcapsular granular type OF cataract may be associated with long-term use of miotics, particularly long-acting cholinesterase inhibitors such as etiothiophate, democarium bromide, diopropyl fluorophosphase, DFP. Removal of the drug may stop progression and occasionally may cause reversal of cataract. Other drug-induced cataracts. Other drugs associated with fine toxic cataracts are amiodarone, chlorpromazine, busulfan, gold and allopurinol. Radiational cataract. Exposure to almost all types of radiant and